Welcome to The Explainer. Today we're going to dig into the SERENA 6 trial, and this is a big one. A study that could really fundamentally change how we approach first-line therapy for our patients with ER-positive, HER2-negative advanced breast cancer. So here's how we're going to break it down. We'll start with the clinical problem we're all trying to solve, then we'll walk through how the trial was designed. After that, we'll get into the exciting stuff, the results, and then talk about what it all means for us in the clinic. And finally, we'll wrap up with the bottom line. Let's jump in.
Okay, first things first, let's set the stage with a problem we all face every day in the clinic, and that's the challenge of acquired resistance, what happens when our best frontline therapy eventually stops working.
You know, we all know the standard of care. For first-line treatment, it's an aromatase inhibitor plus a CDK4/6 inhibitor. It's a fantastic combination, it works really well, but we also know, for pretty much every patient, that resistance is a matter of when, not if.
So, what's the mechanism here? What's driving this resistance? Well, more often than not, the primary culprit is a specific genetic change, a new mutation in the ESR1 gene. You can think of this as creating an estrogen receptor that's basically stuck in the on position, completely independent of estrogen.
And this is not some rare event. We're talking about roughly 40% of our patients developing one of these mutations by the time they progress. And once that happens, our aromatase inhibitors, which work by starving the tumor of estrogen, are pretty much rendered useless.
So this leads to a really critical clinical question, and it's really the whole idea behind the SERENA 6 trial. If we can see these mutations popping up months before a patient actually progresses on their scans, can we use that information? Can we intervene early to extend the benefit of that first-line therapy?
So how did the investigators actually test this hypothesis? Let's take a look at the trial design, because it's pretty clever.
The design here is really innovative. They started with patients who were stable on their first-line AI and CDK4/6 inhibitor. Then they started doing surveillance with liquid biopsies every few months. The moment an ESR1 mutation was detected in the blood, and this is key, before there was any radiographic progression, that patient was randomized. They either switched their endocrine therapy to the new oral SERD, camizestrant, or they continued on their standard AI. Everyone in both arms stayed on their CDK4/6 inhibitor.
So who are the patients in this trial? Well, you can see the two groups were really well balanced. Median age right around 61, a good number with visceral disease. This looks a lot like the patients we see in our own clinics. And not surprisingly, the vast majority, about 3/4 of them, were on palbociclib.
The main question, the primary endpoint, was all about progression-free survival. Could this preemptive switch actually delay the time until the cancer progressed? This is, of course, a hugely important endpoint for both us and our patients.
All right, now for the part we've all been waiting for, the results. Did this strategy actually work? And, just as important, what was the safety profile like?
The results for the primary endpoint were, to put it mildly, striking. In fact, the efficacy signal was so strong that the results were reported at a planned interim analysis.
Just look at that hazard ratio, 0.44. We don't see numbers like this every day. This translates to a 56% reduction in the risk of progression or death for the patients who switched to camizestrant. And of course, it's highly statistically significant.
So what does a hazard ratio like that mean in terms of actual time for our patients? Well, it's a huge difference. The median progression-free survival jumped from 9.2 months in the standard of care arm all the way to 16 months in the camizestrant arm. That's an additional 6.8 months without progression. That is absolutely a clinically meaningful benefit.
Now, the next question we always ask is, was this benefit driven by one particular subgroup? And the answer here is a clear no. The benefit held up across the board. Didn't matter which CDK4/6 inhibitor they were on, whether they had visceral disease or not, or even when that mutation was first detected. It was a consistent benefit.
Okay, let's talk safety. What's the trade-off here? Well, camizestrant did have a higher rate of grade 3 or higher adverse events, but that was mostly driven by neutropenia, which is something we're very used to managing with CDK4/6 inhibitors. The main new side effect was something called photopsia, seeing flashes of light, but it was mostly mild. But here's the real story on tolerability. Look at those discontinuation rates. Almost nobody in either group had to stop treatment because of side effects.
And honestly, this next slide might be one of the most important takeaways from the whole trial. It's not just about adding months to progression-free survival. It's about adding good quality months. Patients who switched to camizestrant maintained their global health status and quality of life for a median of 21 months. Compare that to just over 6 months for those who stayed on their AI. That is a massive difference and a really critical part of the conversation we have with our patients.
So let's bring this all together. We've seen the data. What does this mean for us in the clinic? How do we actually translate this into our day-to-day practice?
The authors themselves are pretty direct in their conclusion. Their findings suggest that this proactive strategy, switching based on ctDNA detection, significantly delayed disease progression compared to our current standard of care.
But of course, before we all rush to change our practice, we have to acknowledge the limitations. First, the overall survival data is still immature. We need to see that. The trial population wasn't as diverse as we'd like, with Black patients being particularly underrepresented. And then there are the practical questions, right? What's the best schedule for ctDNA monitoring? And how does making this switch early affect our treatment choices down the road, in the second-line setting?
So this really forces us to ask two key questions. First, do my patients look like the patients who are in this trial? And second, what are the real-world logistical and financial challenges of implementing routine ctDNA monitoring in a busy practice?
So after looking at all the data, the benefits, the risks, and the unanswered questions, what are the key actionable takeaways for our practice right now?
I think we can boil it down to three main points. Number one, the strategy of preemptive switching works. It's clearly superior to waiting for progression. Number two, the benefit is substantial. A nearly 7-month improvement in PFS is a big deal. And number three, the risk/benefit profile is favorable. The side effects are manageable, and that quality of life data really seals the deal.
You know, the results from SERENA-6 really do suggest a paradigm shift is on the horizon. It leaves all of us with a really practice-defining question. Is it time to make routine circDNA monitoring and preemptive switching the new standard of care for these patients? Based on this data, the argument is getting very, very strong.